Well, I'm Pauline Prue. I am the Executive Director of the ALS Evergreen Chapter. And before I introduce Dr. Elliott, as I mentioned, we are recording this, so we will have the webcast available to share later. Most of you on this webcast already know Dr. Elliott. He is currently the Executive Medical Director of Neurology at the Swedish Neuroscience Clinic, and he is the Medical Director of the ALS program at Swedish. Dr. Elliott was the principal investigator for the Swedish site in the trial assessing AMX 0035 on ALS. The ALS Association supported the development of AMX 0035 with a $2.2 million grant in 2016. And this was one of the first research grants funded with ALS Ice Bucket Challenge donations. So we appreciate that. And with that, I turn it over to Dr. Elliott.
Thank you so much, Pauline. And we should have our slides queuing up here. I'd like to thank Pauline and everybody at the Evergreen chapter of the ALS Association for inviting me to come and share this presentation with you all today. Let's just see. I've got, good. Okay. So today I'm going to review the data from two recent publications that was studying this agent AMX 0035. It's got sort of an interesting name right now. I'm sure that's going to evolve, but for right now, that's what this combination drug is known as. See if I can advance this. Jackie, have you given me, control to advance? Okay. Whoops, I overshot. Let me go back. Okay. So the first thing I want to talk about is a little bit about the origin of these drugs that have been recently looked at and investigated in the treatment of ALS. And many of you may have read about this, that there were two pretty young investigators. Actually, they shared college dorm room back in Brown in 2013. And these two bright, inspired young investigators thought about the potential of two agents that have been shown promise in potentially in treating neurodegenerative diseases. And so they brought that idea forward and had met with others at Massachusetts General Hospital who convinced this young duo, if you will, to look at the use of this combination drug in ALS. As Pauline mentioned, there was grant funding. There were various steps taken along the way that led to the initiation of the trial in collaboration with a group called NEALS in 2017, and a number of sites were designated across the United States to look at this combination drug. This brings us all the way forward to this year that now we have results published in the New England Journal of Medicine pretty recently, about a month ago. And I'm going to share some even more recent data that was published last week in Muscle and Nerve that these studies have evaluated the effects of this combination drug on ALS. Let's see if I can. Okay. Whoops. I got kind of a delay, so I'm sorry, everybody, if I'm advancing out of sequence there. This is just a map to show the different sites across the United States where this trial took place. You can see a fair number in the Northeast. As I mentioned, Massachusetts General Hospital was really the origination site where the principal investigator practices. But there were a number of sites. We were fortunate enough to participate at Swedish and a number of sites across the country. A little bit about these agents, because I think these are kind of obscure compounds, and certainly the name AMX0035 doesn't help to explain kind of where these came from. But TURSO, which is tar-urosodiol, is actually a component of bile acid. This is actually in humans in trace amounts. And interestingly, this is sort of a fun fact, if you will. Large amounts of this are found in bear bile, which is strange, but this is in animal bile. And I think what's interesting historically is that the Chinese and Chinese medicine, they've used animal bile for hundreds of years to treat various ailments. But it was hypothesized over the years that this might have a neuroprotective effect. And there were a number of studies done over the last couple of decades that showed that this TURSO agent does have a cytoprotective effect, that is, a protective effect on neurons, acting through endoplasmic reticulum stress, so intracellular mechanism to help keep neurons alive for longer, if you will. In 2016, there was a study suggesting that it might have benefit in ALS, and so that kind of brought forth this agent as a possible treatment for ALS.
By a bear?
Yeah, right. Sodium phenylbutyrate is a drug that is an aromatic fatty acid. It has been used over the years to treat urea cycle disorders in children. It was FDA approved for that purpose in 1996. And it also, over the years, have shown in various studies to have protective effects in neurodegenerative disease. In 2009, there was a study that showed in a population of ALS patients that it was tolerated and that it may have benefit. So that kind of where this idea came from. And these two students combined these agents in the study that I'm going to talk about. So in terms of its mechanism of action, these agents have been shown to target, as I mentioned, the endoplasmic reticulum, as well as the mitochondria, to help keep neurons alive longer, basically. So neuroprotective effect to buffer the stresses of a disease state to keep neurons alive for longer. And this has been shown both in clinical trials as well as in cell cultures in basic science studies. And it's a fair amount of drug in terms of the dosing. It's 3 grams of phenylbutyrate and 1 gram of TURSO that actually is administered. Initially in the trial, people were given a 1 sachet once daily, and then this was increased to 2 sachets once daily after 3 weeks if tolerated. So there was a titration in the study. There were specific instructions on how to administer this. This could be administered orally, or it could be administered via a feeding tube. And there is a taste disturbance that was reported by a number of the participants. So some people would use various strategies to kind of offset the taste. And there were certain guidelines or recommendations about avoiding fruit juices, that this might make the flavor worse, but it did need to be, this packet did need to be dissolved in a liquid in order to administer this. And how the initial study, which was known as the CENTAUR trial, was set up. It was set up as a randomized, placebo-controlled, double-blind trial. And there were certain eligibility criteria that I've listed here. People involved in the trial, entered into the trial, had to have definite ALS, and there's criteria for that. Very strict research criteria, actually. Had to have disease less than 18 months from the time of symptom onset, and had certain parameters from a respiratory standpoint, had to be over 60% in terms of vital capacity. And then the participants were randomized 2-to-1. That is 2 patients to treatment for every 1 that went to placebo. So there was a treatment arm and a placebo arm. And then the study took place over a 24-week period. This is during this experimental phase. The primary endpoint, the main objective of the study, was to look at the ALS-FRS. I know many on the webinar today are familiar with this scale, but that's a scale that's used to assess function in patients with ALS. There were a number of secondary efficacy endpoints. We tested limb strength using a machine called the Atlas. I'll talk to you a little bit about that. There was a biomarker called phosphorylated neurofilament heavy chain that was measured in the participants. Pulmonary function was measured, and then of course there was survival as another endpoint. So just a little bit about the functional rating scale, and I know many of you are familiar with this, but the ALS-FRS-R, that stands for ALS Functional Rating Scale Revised. It was revised years ago, measures a number of functions: upper extremity, lower extremity, breathing, swallowing, and speech, or bulbar. And there are 12 questions. Each have 4 points, 0 to 4. And basically, speech, salivation, and swallowing are the bulbar components. There are components under fine motor, gross motor, and breathing. So basically, with these 12 questions, 4 points each, you can get 48 points total on this particular scale. And this is what was recurrently measured as people entered into the trial and during the course of the trial to see what type of effect these drugs were having on disease progression. In addition, this trial looked at some strength, and this is one of the very few trials that did utilize this Atlas device, which baseline measures that were predicted based on people's age and gender. Baseline measures were determined for each of the participants, and then depending on how their strength was during the course of the study, we knew percentage-wise how their strength was changing over the course of the study. We measured grip, elbow flexion, extension, lower extremity strength, which was knee flexion extension, basically bending and straightening your knee, and then dorsiflexion at the ankle, that is elevating the foot. And it was measured using this device, so we had basically a very good assessment of strength and how that was changing during the course of the study. And then, as you can imagine, during a trial like this, there are people, a certain number of people that come into the trial. There's a randomization that occurs. And then during the course of the trial, there are people who drop out for various different reasons. And so what this slide is depicting is how initially there were 177 people screened. Some were excluded because they really just didn't meet eligibility criteria. There were ultimately 137 people randomized. And as I mentioned, there were 2 people in the treatment group for every 1 in the placebo group. So you can see that those proportionate numbers here. 2 people were lost to follow-up out of the treatment group. So we ended up then with 48 and 87. And then as the study went on, there were some patients that dropped out, again, for various reasons. And ultimately, at the end of the trial, there were 38 and 67 that completed that 24-week trial. This is not an unusual pattern in ALS studies. We often see this type of phenomenon as people continue through a clinical trial like this. So I want to talk a little bit about baseline characteristics. What did the people look like in each of those groups? And one of the things that's really important when you start a trial like this is, were the people the same or at least similar in each of the groups, in the placebo and the treatment group? And in fact, they were very similar. As I mentioned, there were 137 participants. The average age was 57. There was a certain amount of time, 13.5 months since symptom onset and 6 months since diagnosis on average. There were some differences. We did allow participants to take edaravone or Radicava as well as riluzole during the trial. And in fact, 77% were on one or the other or both. As I'll show you, more of the patients in the placebo group were actually on riluzole and edaravone than the treatment group. Here's a slide that shows the baseline characteristics of each of these groups. So you can see the percentages of each group is depicted here in the parentheses. So very similar gender comparing placebo and the treatment group. Similar ethnicity, age was very close, weight and BMI. And then other characteristics like the amount of time since symptom onset, months since diagnosis, the distribution of bulbar onset, meaning affecting speech and swallowing, was a little bit different between the groups. In fact, a little more of patients in the treatment group had bulbar onset, which typically is a little faster progressing. So if anything, that puts this at a disadvantage in my mind. And then the baseline ALS-FRS slope, meaning how were people progressing as they went into the study, was very similar between these two groups. This is some more detail about comparing the two groups as they're going into this baseline characteristics. Very similar scores on the ALS-FRS going into the trial, and very similar scores on this ATLAS or strength testing, as well as respiratory measures. So the importance of showing this is that the two groups were not really different. There were a lot of similarities between the placebo and the treatment group, and this was assessed in fair detail, as you can see here. What was a little bit different is that we had proportionally more patients in the placebo group who were taking riluzole, 77% compared to 68%, and more, 50% compared to 25%, were on edaravone. If anything, again, this would put the treatment group a little bit at a disadvantage, assuming that there are therapeutic effects of those drugs. So kind of take that into consideration as we move through the data here, but we actually had more people on these treatments in the placebo group than the treatment group. And now I'm going to talk a little bit about the results of the trial. And the primary endpoint, as I mentioned, was the ALS-FRS-R. And what this study showed, just going to move something here, is that each, the total difference at the end of 6 months was 2.32 points comparing the placebo group to the treatment group over that 6-month period of time. I'm going to show you some more detail on that, but this did meet statistical significance and was suggestive that the study had met its primary endpoint and that there was an effect on slowing rate of progression in ALS. A little more detail, though, I think is helpful here, is that when you look at each week is depicted here on the x-axis of this graph, you can see the placebo rate of progression is shown here in blue. That is patients taking placebo, and the treatment group here in red. And you can see there was definitely a separation that occurred as the trial went on, where the rate of progression in the treatment group was not as steep as it was in the placebo group. So in terms of per month, the rate of progression in the treatment group was about 1.24 points per month, as opposed to placebo was 1.66. So this did meet statistical significance with a p-value of 0.03. If you are at a p-value of 0.05, that's felt to be statistically significant. So this separation that we observed, it was felt this wasn't just random or by chance, that there really was a true separation between, over a 6-month period of time, between these two groups. So to think about this a little bit more is that participants receiving treatment had the same total score after 24 weeks of treatment as those in the placebo group did at week 18. And you can see that green bar here. In other words, it's as if there was kind of a 6-week increase in retained function, is what's implied by this, over a 6-month period of time. And I wanted to share some of the data on specifically the subtypes on the ALS-FRS. So as I had mentioned earlier, that there are various domains in the functional rating scale. There's the bulbar, the fine motor or upper extremity, and then gross motor, lower extremity, and breathing. And this graph, I'm sorry, this is a little bit of a busy slide, but this shows that if the active treatment is better, we would expect the dots to be on this side of the dotted line. And you can see for each domain, we're showing a benefit towards treatment. And here's actually the numerical score. So this should reach a score of 12. And you can see that a lower number would be worse. So placebo had the placebo group here all had lower numbers compared to the counterpart of the treatment group. So it was consistent across all domains that there seemed to be a benefit to being on treatment compared to placebo. It wasn't just one domain in particular. Now, statistical significance, when you separate these out, really was more in the fine motor group. You can see the p-value is over here. But I think the important thing, the take home, is that there appeared to be a consistent effect across every domain of the ALS-FRS, which is, I think, helpful and makes this even a little bit more compelling. I want to go into some of the secondary endpoints. The secondary endpoints, as I mentioned, included the strength testing with this atlas. So we're measuring upper extremity, lower extremity strength testing, as well as the effect on the vital capacity or respiratory function. And just like the last graph I showed you, again, this is kind of busy, but there was a trend, again, towards benefit for all of these secondary measures. So you can see all of the dots are on the beneficial side, the treatment side, as opposed to the placebo. If you look at the scores for each of these, if you look at the total strength score, that is for the atlas, you can see the placebo group had a lower score than the treatment group. And that was consistent across each domain. Also, respiratory function was better, comparing the treatment group here to the placebo group. Now, unfortunately, except for the upper extremity strength testing, that was statistically significant, but none of these other secondary measures met statistical significance. So the secondary outcomes in terms of strength and breathing showed definitely a trend towards benefit, but none of these really were convincing in terms of statistical significance. Okay, a little bit on side effects, and this is, safety and side effects, very important whenever you're looking at any treatment. And this does require a little bit of explanation in that every single adverse event that a participant had, whether it was related or not to the drug, was reported. So you can see here, there are a number of different categories: GI, musculoskeletal, neurologic, infectious, and then there were percentages of participants that experienced these various side effects, both in the placebo group here, as well as in the treatment group. I've put in red those areas where the treatment group had a little higher incidence, if you will, of these types of side effects. And that occurred in gastrointestinal, respiratory, and in the cardiac disorders here. This does require a little bit of explanation in that the cardiac disorders, these were very minor changes that were seen on EKG. There were a couple of patients who developed atrial fibrillation, and there were very small numbers, and it was very hard to really make out what that meant. There was a difference, but it wasn't felt to be, there weren't any really significant safety issues there, even though we think of cardiac as being, critical. Certainly, that none of these were serious in nature, I would say. Likewise, there were a number of respiratory and thoracic and mediastinal disorders listed that were different between the groups, but again, no clear signal, I would say, of great differences between the groups, even though in totality there were some differences. I think looking deeper in the data, the biggest difference that was seen was in GI side effects. And it is known that terso and phenylbutyrate can have GI side effects in people. So this was felt to be perhaps the most important signal out of all the side effects and adverse effects that occurred in the trial. And just to go a little more in detail, whoops, let me go back. When you look at GI side effects in detail, in particular, there were, in the treatment group, there was a little more in the way of diarrhea, more in the way of nausea. But importantly, and I would say this was certainly my experience as an investigator in this trial, we tended to see these complaints a bit more early on in the first 3 weeks of the trial when people were first kind of getting used to the medication. And then they, as with time, they did really seem to kind of taper off. So bottom line is that gastrointestinal side effects, that does appear to be an issue that some patients taking this may experience. Otherwise, I would say the study showed pretty good safety side effects overall in terms of tolerability of this drug. Whoops, boy, I'm getting like a double click there. Before I go on to the second half of the talk, just as a take home, in terms of the results, the main take home I would say is that the rate of progression, the difference in the treatment group was that there was a slower rate of progression with a loss of 1.24 ALS-FRS points per month compared to placebo of 1.66. So that primary endpoint in terms of just disease progression does appear to be significant. And keep in mind, that's only over a 6-month period of time. So this potentially there could be benefit over a longer period of time, the longer that somebody takes this. Secondary outcomes, including the strength, the vital capacity, did not differ between the groups. So there was not, there was a trend, definitely, but these secondary measures did not meet statistical significance. And as I mentioned at the beginning of the presentation, there's this very, very recent publication, you can see here, October 16th, that we've just released the long-term survival data on this trial, which extended over a 3-year period of time. And I'm going to share that with you all today. This is all extremely recent, and also importantly demonstrated benefit. So I think added to the effect on disease progression, the data on survival is looking promising. So the trial was set up with what's called an open label extension. And I'm just going to, again, kind of walk everybody through this, that participants were screened. Then there was the randomization, as I mentioned. Participants were then, over this 24-week period of time, either in the treatment arm or the placebo arm. And then at the end of that 24-week period, and it's a very typical design for clinical trials, there was what's called an open label extension, which means everybody in each group gets drug if they want it. So 90 of the 98 participants elected to continue in what's called the OLE, or the open label extension phase. And this lasted for several months, where these participants were followed. So the cutoff date was July 20th. And over that period of time, survival was assessed. Now, many of the participants in the trial had kind of moved on or had left the trial. And so there was a methodology used to assess what happened with everybody who was in the trial. And this was a process used called OmniTrace, where whether people who were in the trial were still alive and survived, or if they had passed. And so this is very important in any clinical trial, clearly, to see how are people doing over a longer period of time. You really want to see, is it having an effect on survival? Are people living longer? And we had 48 participants in the placebo group and 89 in the treatment group. This assessment of survival was actually complex, but used this methodology to, over a longer period of time, see how people did. And this graph probably is the best way to understand how this was calculated, but it takes a little bit of explanation. And if you will, as I mentioned at the beginning, that patients were separated into a treatment group and a placebo group. And that's shown up to this dotted line, that people were in the trial and the placebo patients up to that were receiving placebo up to this bar here. So there's the treatment phase. But in this open label phase, people were given the option to continue on drug. So you can see here are a number of the participants continuing on drug in the open label phase in the treatment group, and several in the placebo group continued on treatment. Overall, the people who were in this treatment group received drug on average for 8.8 months. And overall, people who were in this placebo group received it far less, as you can imagine, only 1.9 months on average. So what the study did is they compared this group in totality with this group. How did each group do in terms of survival? How did the group who was exposed for drug longer do compared to this group who was not exposed as long? And as you can see here, let me just make sure I didn't miss one. There was a difference between these two groups. And on average, what's called the median survival, that is where the half of each group of patients is alive, that the group that entered the treatment phase survived for 6.5 months longer than the group who were on placebo. So that's a pretty significant difference over a 3-year period of time, that there was a 6.5 month benefit. I would keep in mind that 77% of the participants were either on riluzole or edaravone prior to entering the trial. As I mentioned early on, most of those patients who were receiving those agents were in the placebo group, disproportionately compared to treatment. And as I mentioned in the last slide, the treatment group on average had 6.9 months longer exposure to the treatment than the placebo group, and hence the benefit of 6.5 months. So to just even kind of break it down a little bit more, the median survival for the group that was originally randomized into treatment was 25 months compared to placebo. Median survival was 18.5 months, and that equates to a 6.5 month benefit. So I think taken together, before we open this up to discussion or questions, this is one of very few, in fact, this is the only trial in ALS that has shown a benefit in both disease progression, changing the rate of progression, as well as survival. There have been other trials, like with edaravone, for instance, that looked at rate of progression and showed benefit, but they did not demonstrate benefit in survival. Similarly, riluzole never demonstrated a benefit in disease progression, but did demonstrate a benefit in survival. And so this trial is the first that demonstrated both. So I think that's why there's some enthusiasm about the results that I'm sharing with you today, is that there was benefit in progression and survival. So it does appear that this combination drug is having an effect on disease progression, which is, that's a important part of breaking down treatment for ALS, where we just haven't had treatments, that now there's something that looks like it's having a neuroprotective effect and slowing the disease down. Before we open up to questions, I will say that it's not a home run, right? I mean, we'd love to stop progression. We'd love to reverse disease progression. That would really be something. So I know many of you are, rightfully hoping for something like that, but this is still a positive result. And with the really dozens and dozens of trials that have happened in ALS where we haven't seen benefit, this is a nice change. And this is what's prompting the company to apply for FDA approval for this combination drug. So with that, maybe I'll turn things over to Pauline. I don't know if, Pauline, you were going to moderate. And actually, yeah, we can skip that one. Yeah.
Thanks, Mike.
Yeah.
We do have some great questions. Let's see. We have Angela Frederick asked, I also have secondary adrenal insufficiency and I'm on chronic prednisone. Do you know if this new drug will interact with the prednisone?
That's an excellent question. I do not believe prednisone was one of the drugs that was excluded, that excluded people from participating in the trial. I'd have to go back and look at the detail on that. I would mention, and please keep in mind, that these are clinical trials that have been published, but this isn't yet FDA approved for use. So guidelines related specifically to what other drugs you can take and what you can't take, we will need to wait to hear from the FDA for specific guidance on that. But I can tell you just my gut and from what I know, I don't think that would exclude you.
Okay, and Steve Horn about the ALS FRS scale. Question, why is fatigue not on the scale?
Boy, that is a very good question. I think fatigue is pretty ubiquitous, right? I mean, I think every patient I see certainly has fatigue. And I think therein may lie the problem, is that fatigue is it's somewhat of a non-specific complaint that people have, certainly with ALS, but they have with a lot of other things as well. So I think, although you're right, it's common for patients with ALS to have fatigue. It's also very non-specific. And so because it lacks specificity, that's probably why we haven't used fatigue so much in that type of scale.
Okay, and Oliver had a question about expecting insurance companies to cover this medication at the trial parameters, or is it just generally prescribed for anyone with an ALS diagnosis?
Again, excellent questions. Thanks, Oliver. So as many of you on the call may know, the precedent for this really is that precedent came forth with edaravone. And initially, edaravone was studied, or Radicava was studied, and it did not show benefit in a larger group of ALS patients. But then when there was a sub-analysis done with edaravone with patients who had disease less than 2 years, had greater than 80% of their respiratory function, and had fairly good results on their ALS-FRS baseline, that they did show a significant treatment effect. So because that's how the second study was done, the insurance companies have since said, well, we'll approve it, but we're only going to approve it if people meet these parameters, like what was shown in the trial. So we don't know yet with the CENTAUR trial, will there be boundaries in terms of which patients will be covered if it gets FDA approved? Will there be boundaries from an insurance standpoint of which patients will be eligible for insurance coverage? As I mentioned, there were some inclusion criteria. Less than 18 months was one. The other was clinically definite ALS was another inclusion criteria for the trial. My hope is that there aren't such boundaries, that we can give this to as many patients with ALS as who want to take this, but we'll have to wait and see. We don't know the answer to that yet.
Thank you. Valerie had a good question about availability in the Seattle area and cost as well, and I think you pretty much addressed it in your last answer. Anything about in the Seattle area? We're just waiting, as is the rest of the country, I take it.
Yeah, we're really waiting now. I mean, the ball is sort of in FDA's court right now, and we'll have to wait and see what happens. I know many of you have signed petitions, and the ALS Association has helped, really to kind of push and get the word out that people, would like this to see a rapid process through the FDA. Many trials, for a drug to be approved, need to go through a phase 2 as well as a larger phase 3 trial with bigger numbers and more safety data and more data that pertain to effectiveness. But I think that the company's arguing that they have good data from this phase 2 trial, so they're certainly arguing to try to get FDA approval, and also given the nature of ALS too. I think it's different than many disorders in terms of the gravity of the disease.
Okay. And can you take the new drug by itself, or do you need to add the others that you mentioned before for it to work?
Yeah, okay. Yes, you can take it by itself. And I didn't show it here, but I believe there was benefit for all groups. So as I said in the trial, there were many people who were on Radicava and many people who were on Riluzole. In fact, the majority of patients were on these other drugs, but many of the participants were on neither, and also, I believe, demonstrated benefit. So it's not necessary that you take all three.
Okay. When you talk about participants' upper motor skills, will it help the motor skills improve if it is already lost? Right.
It won't help them improve. I wish, like I said at the end, I really wish it had that type of an effect. What we believe it will do is it will preserve the motor skills you have for longer. So it won't let you lose them at the same rate you would be losing them as if you were taking nothing.
Okay. Are any of the participants continuing the drug currently?
Right. So the open label extension has now ended, and everybody has pretty much gone through that. There may be a further phase with data collection for people who were in the trial to continue it for longer, and that's being set up right now.
Okay. And a couple questions are in regard to the most suitable participant. Is the most suitable participant based on lower ALS-FRS or time frame after diagnosis? And then I have a similar one from Priscilla about differences between a younger participant and an older participant in treatment group function and survival.
Mm-hmm. Yeah, so as it pertains to the first question, that question really relates to the early stage of the disease or the latter stage of the disease. And at least in my mind, because there was a benefit every month that participants took the drug, in my mind, I would think the earlier that you're on this, the better, that you would begin to gain that slope, that decreased slope benefit, right away. So the longer you're exposed, that appears to trend that you have potentially more benefit. Now, that's not to say that people who are later in the disease shouldn't take it. But I think the opportunity may be greater for people who are earlier in the stage of their disease.
Okay.
And then I think the second question related to age. Is that correct, Colleen?
Any statistical difference between younger participants and older participants in treatment, function, and survival?
That's a good question. And I don't know the answer to that question. And I'm not sure that was looked at in terms of an age difference. Not that I know of, but I honestly don't know the answer to that. Yeah, good question.
And let me just go back through. Can you take the drug via a feeding tube?
Yes.
Okay. Would you prescribe to patients with PLS?
Right. That's also a very good question. Would I? I might try, but I think the problem I would hit would be insurance. I doubt we would be successful in getting insurance authorization for this for patients with PLS, because it's still really considered a different disease. So when we looked at those inclusion criteria at the beginning of the trial, people with PLS wouldn't meet the criteria, and I think insurance companies are going to definitely draw a line there.
Okay.
Now, that comes up a lot for our patients with PLS, though, and that should a patient with PLS take Riluzole or Edaravone, and some people believe that PLS is on a spectrum with ALS, and that this just represents more upper motor neuron dysfunction, but that there's a lot of overlap here in terms of the mechanism. It's just affecting a different part of the nervous system. So I think from a theoretical standpoint, it's really interesting, and whether future trials will, be nice if we had future trials in PLS, but I don't think insurance is likely to cover it at this stage.
And then, Dr. Elliott, could you just give us a quick little definition of what PLS is for those of participants on the call who may not be as familiar?
Yeah, yes. So PLS is called primary lateral sclerosis, and PLS is different from ALS in that, I'm sorry I don't have a diagram to show all of you, but with ALS, there's a combination problem where the neurons descending from the brain down into the spinal cord, as well as the neurons in the spinal cord, which are called the anterior horn cells, both these groups of neurons, the upper system and the lower system that sits in the spinal cord, are slowly dying, that we see degeneration in the upper and the lower parts of our nervous system. In PLS, we do not see degeneration within the spinal cord. We just see degeneration of the upper motor neurons from the brain descending down into the spinal cord. And as a consequence, patients with PLS have a lot more what we call spasticity, meaning their reflexes are very brisk, and they have a lot more tone because they aren't having this inhibitory signal from the brain to calm down the lower system. So movements become there's more stiffness and less synchronous movements for patients with PLS. I'm giving you a very long answer here, but I want to say that patients with PLS live longer typically. And the reason for that is that they don't have that lower system affected, which is typically is what is hitting the diaphragm in patients with ALS. And so patients with PLS typically have pretty good respiratory function that's preserved during the course of their illness. So that's kind of a long-winded answer, but that's the answer.
Okay, thank you. TUDCA came up, and I've heard it before. I'm not 100% sure I'm that familiar with it, but TUDCA is available, Steadfast, and can it be taken by itself? Can you give us a little background on it?
Yeah, so that's correct. TUDCA is basically the same thing as Terso. And so it is a bile acid salt. It is available. You can get TUDCA. One of the differences I would say is that, the company mentions the number of differences here. That one is you don't really know when you order TUDCA online exactly how much TUDCA you're getting. It's not controlled or regulated. But this is true. This is something that people can get, online. You can order TUDCA, and it's available in a pill form.
Okay, and it is supposed to. What is the benefit of it?
Well, there were some small trials that have suggested that TUDCA by itself may have a neuroprotective effect in patients with ALS. So theoretically, and again, small trials were not 100% confident, but that this potential is, in theory, could be a beneficial treatment for ALS by itself. Obviously, the studies that I showed you spoke more to the combination of Terso, which is just another name for TUDCA, and phenylbutyrate in combination. And so, you can get TUDCA basically at this point in time. Okay.
And we do have a lot of questions about what phase this is in right now. So this is in phase 2, correct? And right now the ALS Association has joined another organization to ask the FDA to skip phase 3. Stop me, Mike, if I'm explaining this wrong. To skip phase 3 and open this up for distribution. Is that right?
Yeah, no, that's exactly right. And I think whenever you have, for instance, if this phase 2 study showed more concerns related to safety, like this is a more toxic drug, that there were some serious concerns regarding safety, I think the FDA would say, no, we need more safety data. We probably need a bigger, large, phase 3 type trial to look at that. And also, if the signal in terms of benefit was, weaker than what I showed you, likewise, the FDA may say, we're not convinced. We need a bigger trial to look at this. So I think this is where the company's coming from. They're saying, we have evidence that shows in 2 domains that there appears to be benefit, and we have pretty good safety data. There wasn't any really concerning signal in terms of safety. And I think for those reasons in particular, they're arguing we don't really need a phase 3 study for a disease like ALS as well. So you put all that into context, and I think that's the argument that the company's certainly pushing at this point.
Okay. And we don't know how much it's going to cost, and we don't know exactly when it's going to be available or at this moment in time. Is that correct?
Yeah, that's right.
Okay, I'm just going to run through some of the other questions. Angela Bartels has a great one. How does the mechanism of action differ from Radicava?
Yeah, that's a very good question. I think it is important to state that the mechanism of action of riluzole, of edaravone or Radicava, and of this AMX 0035, they're all different. They all work differently. But the thing that's similar is we believe that they all have neuroprotective effects. So riluzole works through a mechanism where there's a neurotransmitter called glutamate, and too much glutamate exposure for neurons leads to neurotoxicity and cellular death. Riluzole is thought to have a favorable effect on glutamate and through those means to keep neurons alive longer. Radicava or edaravone works as an antioxidant, again with a neuroprotective effect different than riluzole, but also neuroprotective. And then the AMX 0035 works even different. It has a different mechanism. As I mentioned, the endoplasmic reticulum and mitochondria protection. These are intracellular organelles to, again, have neuroprotection and keep neurons alive longer. So I think that's important, and that's one of the things that may happen over time with ALS, is that if we can add more drugs with maybe even complementary or different types of neuroprotective effects, can we even add to this? Mm. And you think about, Riluzole came out in the mid-90s. Finally, hopefully we'll have a third drug, but I could foresee a point down the road where people are on, potentially multiple drugs, again, to try to slow down the rate of progression of ALS.
Okay, thank you. And then just in a layman's terms, how would you define mechanism of action?
Right, I know. And actually, the mechanism of action is really complicated. And I started pulling some of those basic science papers, and I got lost in about halfway through because they're really, really complex. But in layman's terms, what I would say is there appears to be two components in our cells. This is going to be a bit longer, but I'll do my best. One is the mitochondria, and the mitochondria is where the energy of our cells come from. And this drug appears to preserve and enhance mitochondrial function that allows the cell to live longer. Similarly, the endoplasmic reticulum is helpful for transporting things in the cell. Again, that function is preserved and benefited from this drug. So those two important components of cells appear to be aided, and therein we get a neuroprotective effect. Was that layman terms? I'm not sure.
That wasn't layman terms, but we'll go with that. Now, Mike, you told me you had a hard 1 p.m. stop because you do have an appointment. So I'm going to stop it right there. I'm going to thank you so much for sharing this with us. We are so thankful to have you available. So thank you again.
Yeah.
Just want to let everybody know that we did record this. So this will be available. We will send out a link. We are also going to send out a survey. And what we can do in that survey is if you do have questions, we'll leave a text box that you can enter your questions and we'll try to get those answered. All right. Thank you again, everyone. Thank you so much for joining us, and I look forward to your feedback.
Thank you. Bye, everybody.
All right.